My name is Dr. Miller. I'm here to introduce Dr. Haynes, our speaker for today. And you'll see there in the background is Stella, her dog, who's also going to join us. Without further ado, Dr. Haynes is an assistant professor here at the University of New Mexico. She's also the inpatient medical director of geriatric psychiatry, which is her passion. She holds a medical degree from Eastern Virginia Medical School, Master of Fine Arts in dance from the University of Hawaii, and a Bachelor of Arts in psychology from the University of Tennessee Knoxville. She has had a career as a dance artist and educator, and that informs her work as a medical education researcher with special interests in geriatric psychiatry training, humanities and medical education, and DEI. She works in teaching both locally in New Mexico and in the national community to promote quality geriatric psychiatry education and patient care. She enjoys her desert life in beautiful New Mexico with her husband, her two wonderful children, and her dogs, Miko and Stella. Of course, Miko is downstairs. She is going to talk today about perceptions among residents of geriatric psychiatry. Without further ado, Dr. Haynes.
Thanks, Dr. Miller. Appreciate your warm introduction, and hello, everyone. Nice to see all of your names, and thank you for tuning in to talk about a topic, or at least listen to me talk about a topic that means a lot to me, which is quality education and care of geriatric patients. So we're going to get started. I'm going to share my screen. Today we're going to talk about the geriatric perceptions, or perceptions of residents by geriatric psychiatry. This is me and my lovely family. Jeremy already introduced me. And if you don't know me, I'd love to know you better. Reach out. I have nothing to disclose today. During this presentation, we're going to work to describe the patient-provider mismatch in subspecialty care for geriatric patients. We're going to identify both positive and negative perceptions found in one research project investigating resident attitudes toward geriatric psychiatry and towards geriatric patients. And we're going to discuss some curricular interventions that we created and have been employing here at UNM to address these negative resident attitudes. So today we're going to talk about an article that was recently published in Academic Psychiatry. If you would like to take a screenshot of this, a picture of this QR code, you can have the article in full to read at your own leisure, or to follow along if you care to do so as we talk. So this is kind of a celebration for me. This is the first article that I have published as first author, other than a MedEd portal submission. This is my first scholarly medical education research, so I'm glad to be here today to celebrate with you guys. And also I want to thank some of my mentors, Jeremy Miller and Julie Salvador, who helped guide me through the process of learning about being a qualitative researcher and how to really write in a more scholarly manner than I was familiar with previously. So the question begs, like, a lot of times when I come and talk to people, I love teaching and I like to talk about both process and product. Today I'm going to veer more towards product, but I just could not get away from a slide kind of discussing, because maybe you are like I was 4 years ago as a resident watching this grand rounds thinking, how do I even do this? How would I get started? What would be the process? I've never learned about being a researcher before. How does one go from an idea to actually getting published? And so in brief, this is a very quick kind of overview of what occurred throughout this process, which started in my conversations with Dr. Abbott, one of my geriatric psychiatry mentors, about, I would say 4 years ago, and then culminated in the publication just this month. So to speak about kind of the core issue that inspired the research project is that the geriatric population continues to grow while participation in the geriatric fellowship is shrinking. Now, you residents out there, if you have come to my classes, you've seen this slide before where I talk about the demographic reality of the silver tsunami, or the surge of people in late life. And then, some of the data from many of the workforce kind of white papers from the government studying this, it just shows that the proportion of people aged 65 and older is going to continue to increase. all the way like 20% by the year 2030. And at the same time, as one would expect, the number of older adults with mental illness is also expected to increase. It may up to double to 15 million by 2030. Also, by the year 2030, they anticipate that there will be approximately one geriatric psychiatrist per every 5,000-ish older adults with a psychiatric disorder. And these are not evenly distributed. If we even think about like the element of justice, the majority of geriatric psychiatrists are in academic medical centers or very high population density areas. And that's not New Mexico, right? Or places that are more rural or less resourced. So, are we doing anything to kind of address this patient provider gap, this mismatch? There's a lot of talk in the geriatric psychiatry community about how we, noticing the trends and how do we address them. But so far, the fellowship for geriatric psychiatry continues to shrink. 2024-25, there's only 46 fellows. Last year, like the current fellowship year, there's only 42. And that's out of a possible like 120 to 140 spaces for that fellowship. So there's definitely a gap, and there's a big curiosity in the field. Why is this occurring? And part of this gap that's going to cause, I would say, less robust and specialized care for our older adults, combined with certain things that I had been hearing within my co-residents were places of curiosity for me, and I wanted to really see if we could describe them in a scholarly way to use that as data and to kind of address this problem. And so this started for me in PGY4 year. So you guys, it can happen. Our residency is very open to, if you have a project that you want to do, kind of follow your bliss and find your mentors, which is what I did. At the time, there was an opportunity presented to me with Dr. Abbott and Dr. Miller to really expand the geriatric psychiatry curriculum taught in our didactics. And this project kind of grew out of that as part of the needs assessment to figure out, what do residents want to know more of, what do they know enough of, and what kind of attitudes are they experiencing or having towards treating patients in late life. So another thing you may not be aware of is that across medical training, geriatric psychiatry exposure, it's very limited, and there's inadequate resources, curricular time, and geriatric expertise. And this can be, it depends on the area that you're in, whether you actually have geriatric psychiatrists that are trained to provide this type of expertise for trainees. But it's also a more like a national issue, is that like our ACGME requirements, it only has 1 month of FTE. The University of New Mexico, we have it better here as far as some other training areas where there's even less dedicated time to training in geriatrics, because many residency programs don't have a geriatric psychiatrist on staff. And so there's a real dearth of expertise or kind of mentorship that's provided. And there's also very vague curricular guidelines about what trainees should be able to know or do by the end of their residency training. And so the smiley face is reminding me to mention that I'm currently involved in another bit of scholarship from the Teaching and Training Committee at AAGP, where we're trying to propose a series of learning objectives and guidelines for core competencies to residency training programs so that they can kind of match what experts think that residents should be able to know when they graduate versus just leaving them with these very vague guidelines. So that's another bit of scholarship that's coming up that I think is really needed. So at the time of the focus group, the UNM residents' exposure to geriatric psychiatry was across all clinical services, as we're well aware, other than child, that we see older adults on CL and emergency, on the inpatient, in different places that we kind of practice. And there's also the didactics at that time were focused on ECT, late life depression, and dementia. We do have our dedicated FTE for geri psych either on the inpatient unit or the outpatient clinic. So that's we're very lucky in that way. So for the purpose of this research, we were investigating the general psychiatry residents' perceptions of geriatric psychiatry because we wanted to understand why fewer psychiatry residents, like pipeline trainees, were choosing to specialize in geriatric care. So the goal was to identify barriers, seek to create some solutions, and address this patient-provider mismatch. So what did we do? We conducted 2 focus groups focusing on first and second year residents. We wanted to know what challenges they perceived and what benefits they thought there were for geriatric psychiatry as a profession. Why we focused on first and second years was really to capture the attitudes of potential fellowship applicants, kind of understand where these potential applicants were, and then also to conduct that needs assessment for a planned curricular revision. So we analyzed transcripts using an exploratory, qualitative, thematic, team-based approach. And so I learned a lot about qualitative research through the course of this project, which was really great. The first thing I did came with the idea to Dr. Abbott and Dr. Salvador and said, hey, I want to make this curriculum, but I need to know what people want to know and what they need to know more about. So we drafted a series of focus group questions. Then Dr. Salvador and I refined them several times. We went through an educational exempt IRB, which it was a heavy lift, but also a great opportunity to kind of see how that process goes and how it protects research subjects. We held focus groups during the resident didactics. And I want to take this moment to really genuinely thank the residents that took their time to come and share their ideas and thoughts and perceptions with the research team. Some of you are on the call today. I won't shout you out, but I appreciate everyone that agreed to participate. We took audio recordings and then had them professionally transcribed, and then we started the qualitative research analysis. These are the focus group questions. I'll give you a moment to read through them. So you may or may not be done, but what you can see from the questions is that we're generally trying to capture people's ideas and past experiences, both their feelings and kind of look at their behaviors as far as what they perceive about challenges and benefits in geriatric psychiatry, and also to kind of understand what they want to know more about in geriatric psychiatry and what they maybe have covered too much. So within looking at the transcripts, we created a coding structure, which included in vivo descriptions. Now, in vivo is a summary of participants' language. And the point of that is to kind of preserve the participant's voice, because that is one of the special, very rich places in qualitative research, is that it's really reflective of a specific group at a specific time in a really clear point of view. And so throughout this course, the first thing that happened is I went through the transcripts and I kind of created my own preliminary coding structure saying, oh, I notice a lot of this is happening and these themes are coming up often. And then 2 qualitative research analysts came and created, using that preliminary structure, they also created their own thematic independent coding. And then they used the in vivo method. It's a program to kind of really dig into that. We met several times over the course of a couple of months to kind of review and discuss the coding structure. It was very important as the kind of content expert for me to look at the things that had come up and then give them more of an expertise or subspecialty context and kind of discuss a little bit about the experience of the resident and what they may be meaning by certain turns of phrases or referring to specific clinical experiences that were shared. At the end, we summarized the results and ran in vivo queries, kind of looking at the distribution of codes and how they related to the general challenges and benefits of geriatric psychiatry perceived by the residents. So what did we find? So who came to the focus groups? We had 10 participants, 5 were in each focus group, and you can see the breakdown below of different demographic metrics. I'm not going to read it out loud. But I think at this time, it might be, before I share the results, I'm just curious, like, and you don't need to share this, but like, what might be in your mind of what you expect? Like, what are you expecting these residents to have shared about their perceptions of geriatric psychiatry? And kind of why is that? Like, what are the stories or the narratives in our world, in our society about geriatric patients? Or many of us are, I would say most all of us are involved in the health system, and we've had certain experiences with older adults in crisis or in the outpatient more stable care, and how is that coloring our attitudes or perceptions of older patients and caring for them? So kind of just, I want to encourage you to take a moment to kind of notice your own notions or biases that may be coming up. And then just as a point of curiosity, like, I guess compare it to what came up with these participants in our focus group. So as far as challenges that were perceived, we broke it into subspecialty related, patient related, and systems related. So I'm going to share a little bit about subspecialty related first. The residents found that there may be a lack of personal value or meaning in the field, saying that it's sad, dying, and depressing, that maybe society doesn't value it, and certainly it has poor pay. It may be too demanding. Geriatric psychiatrists, gosh, they must be burnt out. They own all the difficult patients with dementia. It's hard to get your patients placed, and family interactions are really complicated and draining. And then also, the subspecialty is probably too complex. These patients are very medically fragile. They've got these overwhelming medication lists. Geriatric physiology is a little bit confusing and unknown, and they're going to have to like manage complex patients. It may be outside of their abilities. And these systems are difficult to manage as well. As far as things that came up within the focus group, patient related, about challenges, perceived challenges of the geriatric patient. One that was brought up was lack of knowledge. Like maybe the residents don't have enough knowledge about what's normal and not normal, or when do I consult palliative care or other services, and like what resources do I really have to provide to the patients and families? And maybe I don't even have enough confidence in, like, if I'm a younger person, do I have enough confidence to tell an older patient that they need to do X, Y, or Z because they have a lot more life experience than me? And what's the point? Like, maybe I feel kind of hopeless that these patients have these patterns that are entrenched for a long time. Can we even change anything? What am I even doing as a doctor? And what am I actually treating? And maybe, older people are going to die, so maybe that's okay, right? Is there a sense of futility or hopelessness in caring for this patient population? How difficult is it to connect with older patients? Maybe building therapeutic rapport is difficult because patients may be seen more lonely and isolated. Maybe they have memory deficits, and that inhibits being able to know your patients or be known by your patients. Oftentimes, residents were tending to infantilize patients. And all this death and dying discussion, that's really heavy. As far as moral injury, caring for these geriatric patients can hurt because it's difficult to watch people to suffer. Witnessing people when they're alone or dying is very challenging, and thinking that you can't make it better as a doctor is not a comfortable place. You can also feel demoralized because maybe you're just medicating patients for placement. So those were the majority of the common things that came up for the residents in relating to patient-related challenges. Now, when we get into challenges to the system, low resources came up, thinking again about this mismatch between geriatric patients that are very underserved and expanding, but also not having enough resources in our current system of care to meet their needs, and that the volume and complexity of patients can be quite overwhelming. Maybe it's too difficult to access ECT or other necessary care, and that the geriatric psychiatry, it's really just an inadequate safety net for patients that have nowhere else to go and nothing else to support them. There was also the issue of stigma brought out. Overall, society and maybe the health system in particular is biased towards geriatric patients. Residents felt they might be fighting an uphill battle against an unjust and inequitable system, and that often psychiatrists are called to not treat the patient, but to treat the network. That the physicians and the systems were more permissive of the wish of an older person to die, maybe than a younger person with a similar presentation, and that older patients were much more likely to lose their autonomy within a healthcare interaction. The idea of discrimination also came up, thinking that placement for our patients with mental health diagnoses is very difficult due to stigma against them, that maybe nursing homes are asking physicians to sedate patients solely so that they can come back to their prior residence or achieve a new residence. And that maybe facilities and providers at those facilities are under or over medicating patients in a dangerous or unwelcome way. So that was a lot. Those were all the perceived challenges that came up in the research. When we turn and look at the perceived benefits and the subspecialty related benefits, residents found geriatric psychiatrists to be highly valued and have needed expertise, that they can provide guidance and support for decisions in late life, especially around dying, and that they do have some highly effective interventions such as ECT. So geriatric psychiatry can be quite impactful. It can also be engaging. Geriatric psychiatry is a very complex and interesting field that prioritizes both medical and psychiatric expertise. Additionally, it can be very meaningful. Geriatric psychiatrists make rewarding longitudinal connections with patients. They can have large impacts with very little changes, and they can see big changes quickly with such interventions such as ECT. And that maybe geriatric psychiatrists focus on the whole person instead of trying to chase a specific symptom or lab. Regarding patient-related benefits, the residents found that there were some rewards. They enjoyed conversations with older adults. They thought that older adults may have wisdom and humor and find meaning when reflecting with patients on their life and memories. Patients and families can be very grateful and appreciative of the work that you do, and that some residents had very positive countertransference from the rewarding relationships they had other places in their life with older adults that helped make the geriatric psychiatry experience rewarding as well. Relating to the system, as far as perceived benefits, they thought that geriatric psychiatry provided a very needed safety net for a frequently poorly resourced and vulnerable population. Now, the final part of the focus group was inquiring about learning goals and used as additional data to support the development of the geriatric psychiatry curriculum. As far as things that residents wanted to learn more about, they included managing complex pharmacology, managing complicated medical comorbidity, more about late life physiology, developmental theory, more about cognitive testing, how you interact with palliative care, how do psychiatric presentations differ in late life? How does one navigate an end of life conversation? How does one accurately diagnose neurocognitive disorder? Can you pull apart what normal aging is versus dysfunctional aging sequelae? Thinking about late life legal concerns and the ethics of late life, and looking at kind of the unique elements of late life suicide risk assessments. These were all things that came up as desired content for a future curriculum. As far as unwanted data within the focus group, residents felt that the MOCA teaching was quite redundant as it was currently presented at that time, but overall they thought they could use more of most geriatric teaching. Okay, so as far as the discussion, part of the goal was really recognizing trainees' perceptions and knowing that this is an important step to trying to alter and improve the training pipeline by addressing misconceptions of the field. So one strength of this study is that it is a novel qualitative approach. I did a lot of research about other studies, and there are many researching this idea of what are the attractants, what are the barriers to residents doing a geriatric psychiatry fellowship? And, we're not going to talk about financial barriers or resource or access barriers or the gap in mentorship. Those have all been kind of well qualified and described within the literature. But this research project is unique because it actually asks and looks at perceptions of trainee pipelines in their own words. And so I think it gives us some more robust and rich detail to kind of latch into when we're thinking about addressing those perceptions and how they may impact their willingness of being a geriatric psychiatrist. Overall, the study found really polarized perceptions about geriatric psychiatry. I will say I was not surprised at a lot of the stuff that came up, even though honestly, at times hearing some of that, the attitudes and perceptions about my chosen profession can be kind of dismaying. But I think that's part of the education of these misconceptions and how we look as a didactic lens or as a clinical mentorship lens to changing them. Also, these attitudes aren't surprising because of some other research that we found when doing the paper. There has been this gap in the downtrend of residents and medical professionals going into geriatric subspecialties is not unique by any means to geriatric psychiatry, geriatric medicine, other geriatric focused medical professions are also experiencing a downtrend in their participation. And there has been some research in the medical schools. Most particularly, we found a pretty large study that looked at medical students' perceptions of caring for older adults, and they really viewed elder care as frustrating and the process of aging as a pathologic state, which I think is a problem. So the question is, can we design interventions to foster positive and decrease negative attitudes towards geriatric psychiatry? And if we can directly address these perceptions, would that result in an increase in fellowship participation? There has been other research that's shown that redesigning medical school curriculums can shift negative learner attitudes about psychiatry. I mean, nowadays we're doing great as far as residents wanting to join this, I would say, the best profession of psychiatry. But in the past, it has had less interest by applicants. And at that juncture, some schools did change their curriculum to just address stigma and perceptions as well as increase exposure to more positive experiences in psychiatry. And that did change perceptions about psychiatry. So there is some evidence that by creating different clinical and didactic educational experiences, you can change perceptions, which I think will lead to a change in or an increase in willingness to join that profession. Unfortunately, little research exists right now applying this strategy to psychiatric subspecialties. And by and large, and by no means am I saying that geriatrics is the only fellowship in psychiatry that is downtrending as far as participation. So with this in mind, we did create a new geriatric psychiatry didactic curriculum, which I think all of the residents listening today had an opportunity to participate in, which is great. We've been delivering it, Dr. Abbott, Dr. Miller, Dr. Hensley, and I have been delivering it for 3 years. We have another research project, which the residents have been wonderfully participating in, looking at filling out skills pre and post curriculum to see if attitudes towards caring for older adults or towards geriatric psychiatry in particular are shifting as a result of that didactic curriculum. So more to come on that. So by no means is this a research project without some problems, right? This is a small sample size. It's also a qualitative study. And these ideas may not generalize to all psychiatry residents, so it does have limitations. The focus group participants were first and second years, and as you may or may not be familiar with our residency, most of that time is spent in higher acuity service areas, and the level of acuity can sometimes negatively impact perceptions of patient populations. We don't have third years participating in this focus group. They are training in less acute outpatient settings, and so that may change attitudes. The focus order questions were first benefits, then challenges. It was actually first challenges and then benefits. If we had changed it to first benefits and then challenges, it could have influenced the participant responses. We did not elect to conduct one-on-one interviews. That may have allowed participants to express more divergent or unpopular views from the main group. So that is a potential gap. And our recruitment process may have introduced volunteer bias because we did not, in our demographic surveys, inquire if any of the residents were planning to pursue a geriatric psychiatry fellowship or if they were planning to pursue a fellowship at all. So what can we do, right? We do have this ever widening patient provider subspecialty mismatch in geriatric psychiatry. And it is, I would say somewhat of a crisis as far as providing the best quality care to our vulnerable population. So can we address these kind of pipeline trainee attitudes that came up and increase participation in the subspecialty? I don't know. Research is ongoing. Thank you so much for being here today, and to all the people that participated to make this this project a possibility. Miller, did you go away?
Sorry, taking a phone call.
Oh, you're doing other work. So now's the time for you can go away. I'll do this.
Okay.
So if anybody wants to ask me questions about this, I'm happy to listen and to respond.
I had a question, Dr. Haynes. So I was wondering if you were able to get, you shared a little bit of demographic data with us about your participants, but I'm wondering if sort of expanding collection of demographic information about your participants may be useful in the future. Should you, you said it's ongoing, should you continue to do this? I'm curious of age and potentially other careers, or I'd just be interested to know if demographics sort of is associated with different perceptions.
Yeah, I think that might be, if I was doing one-on-one interviews, then you'd be maybe more able to map how specific prior, like, we also don't ask about like their prior experience with caring for older adults or any kind of significant or seminal attachment figure that was in later life during the patient's during the resident's evolution. There's some research out there that if someone comes in to medicine knowing that they have those like positive associations, that makes them more favorable towards caring for geriatric populations. So I think there is likely some interesting demographic correlation, but in the purpose of this study, we're really trying to capture like the gestalt or the overall. I'm genuinely happy that there was so much negative perception that came forward because I believe that it has been in the zeitgeist of knowing that it's a hard road. It's like a hard thing to convince people to care for older patients, and this kind of just really qualifies it in a very unique and very specific, detailed, rich, personal story way.
Hey, Wells, can you hear me?
I got you, Will.
Sorry, Dr. Haynes. I was wondering if you could tell us a little more about the process of working with, I imagine, Julie Salvador and others to come up with qualitative research. You probably know that this is a little foreign for me, but it's something I'm very interested in.
Yeah. So thanks for that comment or that question, Dr. Wiley. Yeah, I knew nothing about qualitative research when I was in fourth year of residency. After doing my research elective during third year, I asked Julie to be a mentor to me, and we met weekly. I read a book about qualitative research, and she guided me through the process step by step, holding my hand, which was very useful because it was quite new to me. And so we developed questions, and honestly, I remember at first I made them way too specific, and Julie was like, nah, broaden it, like make it more approachable. And then she, and I don't know if anyone here still knows Lisa Herrera, who is another geriatric fellow that ended up moving elsewhere. But those two conducted the focus groups and got a lot of very rich information. And then I get these transcripts and I'm like, oh my God, what do I do with these? This is just like a lot of data that's de-identified. So I went through with her help and started to like kind of identify themes and put them in buckets. Like this seems mainly a futility idea, or this seems mainly a systems problem type comment. And then there was just a lot of going over that information, like and kind of reevaluating it and then getting other points of view. So that's when CTSC, which is something new now, it's like cactus. So if you guys are interested in that, there are a lot of qualitative research free seminars that you can do as a faculty member or a learner here at the University of New Mexico. And so I went to a couple of those and did some more research on how you do and understand qualitative methods. But then I was guided by the two analysts that did independent coding of the transcripts, and then we all kind of looked at them together and compared and then kind of talked about stuff like, what does it mean? What's the context? What does it mean to say this word as a geriatric psychiatrist, as in like a layperson, that type of thing, and going over the data. So that part was really fascinating and quite time intensive, actually. Did that answer your question, Will?
Yeah, that's really interesting. I've heard about those services before. I was curious about them, but yeah, thanks for telling us a little bit about your experience going through it.
Yeah. And they're super duper approachable and nice. So if you have an idea, I know that they would be willing to talk to you about it and then help you work out what the process would be and how you would do a budget and find that out. A great resource for us.
I could ask a question. Do you think that geriatric specialty is something that people would enter later in a career or early on? And might that make a difference in how you talk about it or train others?
It's an interesting idea. I have in the research I looked at, there was not a lot of questions about whether this was like second career type, like people who were later in the career or having a second type of career, more interested in caring for geriatric populations. There is just not a lot of good data about that. I mean, we can say anecdotally, like Dr. Miller and I were both older and second career and when we came into it, but I think it has a lot more to do with the mentorship. Like the research shows, like if there's quality mentorship in geriatric psychiatry, people are more likely to follow along and do a geriatric psychiatry fellowship themselves. So I'm not sure that there's a lot of data that correlates to the age of the person that is the applicant for the fellowship.
Thanks. And I actually meant also if someone has been a psychiatrist for a while, is it likely they may decide as they get older, perhaps they have more, I don't know, personal interests or, care about the population that might allow them to do it, to work with them?
For sure. I mean, that is the case in some instances. There's a lot of barriers to financial and status barriers to going back into training to go take on a fellowship, but it can be done. It has been done by geriatric psychiatrists in our current community. Not sure.
Yeah, I would say that was my case, and actually Dr. Hensley's case, that we both were general psychiatrists for a while before coming back to the fellowship.
Yeah. But I'm not sure about the trends nationally in that, right?
Thank you. Interesting.
Dr. Haynes, question for you, if you don't mind. In your research of fellowship numbers, you had mentioned that geriatric psychiatry was decreasing, and then you had said that you had seen that maybe in other how does that compare to the other fellowships? I guess are CL and addictions, are those coming down too, or is it
So
pretty isolated to geriatrics?
geriatrics is winning the game to the bottom as far as the steepest decline. And that was exacerbated when so geriatric psychiatry's fellowship was approved in the early 90s. And University of New Mexico got ours pretty early on. As far as that's concerned, once a CL, consult liaison fellowship, was approved, which was a couple of years later, those, like at the beginning of geriatric psychiatry, the numbers were very high and then they started to decline. And once the CL fellowship was approved, the decline became more rapid as far as that goes. So there is this conversation and at the national conferences and stuff about how the biggest competitor for a geriatric applicant is a CL applicant. Yeah. I think I'm not as familiar with the trends and numbers of other specific subspecialties within psychiatry, but I know that overall psychiatry fellowships are less and less filled as a class as throughout the years, that it's more challenging to recruit and attract residents to the fellowships. The exception may be child, but I don't want to confidently speak on those numbers.
And have you noticed in that research that top number, the maximum geriatric fellowships nationally, have those been decreasing as well as the number has dropped, or?
So mostly the ones that are more prestigious or in larger population centers usually fill. But I will say, like the Yale Geriatric Psychiatry Fellowship did not fill for the first time last year. So even places that have a lot more cachet and draw as far as like the ability to get more named mentors and maybe get involved in research, those are also experiencing decline in applicants and fellows.
Oh, to Dr. Holguin's question, is there a collaboration between geriatric training and CL fellowship and didactics? I mean, clearly here with Dr. Hager, we did joint didactics, and so I work with him. In other places, I'm not so sure about, but definitely here, that's the case. Okay, if there are no other questions, Dr. Haynes, wonderful presentation. Apologies for the phone call, but I enjoyed most of it. And thanks again for your passion in education. So I work next door to Dr. Haynes. Used to be next door. She's now down the hall. And so I just want to say that it is always a pleasure to talk to her about education. It is her passion, and this publication was a real win for her and for the department. So thank you, Dr. Haynes, for everything you do for us. We appreciate your expertise.
Thank you, Dr. Miller.
Yeah.
And thanks everyone for being here. If you're interested, if you want to become a first author and you want to hear someone that did it recently, I'd love to talk to you. Hit me up and we can chat. Thanks, everyone.